capital focusing on software investments in vertical markets, including healthcare. He's currently a board observer at CareCloud and IP Commerce. At Intel, Vibhor has also held marketing and finance roles in the graphics and smartphones business units. Prior to Intel, Vibhor was a management consultant at Deloitte Consulting, where he provided consulting services to senior executives at Fortune 500 clients in multiple industries, including healthcare. Vibhor had responsibilities for project management of enterprise-scale engagements, staff development, business developments, and practice management. Vibhor has also served as the director of the Information Dynamics Center of Excellence and managed over 60 people to coordinate practice initiatives in the area of strategic planning, staff training, marketing, and knowledge management. Vibhor has an MBA with high honors from the University of Chicago Booth School of Business and a bachelor's degree in civil and environmental engineering from the Indian Institute of Technology at Kanpur, where he was a recipient of the Dean's Award of Academic Excellence. So Vibhor, the floor is yours.
Great. Thanks a lot, Benoit. So how many people here have heard of Intel Capital? All right, good. So, this question always comes up, right? What is a chip company, doing in healthcare? So I thought I'll go through a couple of slides about Intel Capital, what we do, and how we look at healthcare before I get into trends, just so that, I'm setting the stage for, why is a chip company interested in healthcare. Healthcare doesn't nearly buy as much IT as we would like them to. So one of the reasons Intel is in this business is we want to make sure we get a fair share of the IT spend in healthcare. So, Intel Capital, our core mission for our existence is to be the strategic venture arm for Intel Corporation while providing a financial return for Intel. So we are measured on both of these as far as our value add to our shareholders. So we are just not in the business for doing deals just because they provide a financial return, but we also can do deals because they're strategic, because ultimately the value of your investment only comes from when a company stays in business. A bankrupt company is not good, not of any strategic value to anybody, right? So these are all the areas that we invest in. Starting from enterprise cloud, software, mobility, consumer internet, digital media. By the way, can people in the back hear me okay? Yeah. Okay, thank you. So, bringing it back to healthcare, we think the healthcare IT market is heavily underserved by all these technologies, right? If you look at how much financial services spends on these technology, how much manufacturing spends on these technology, healthcare spends a fraction relative to the total spend in healthcare as percentage of GDP. So, healthcare spend in the United States, it was in Benoit's slides, over $2 trillion. Healthcare IT spend, $30 billion, right? A very, very minuscule fraction spent on healthcare IT relative to what we spend on frankly, unnecessary care, right? Care that's not coordinated. So our core mission and vision and charter as far as healthcare investment is, how do we bring cloud computing to small physician practices? You think about a small physician practice, a 3-physician practice, no CIO, nobody that knows anything about IT. Those guys get out of medical school, all they want to do is take care of patients, right? They don't want to sit around fiddling with servers in a back closet that go down every so often and and deal with tablets and iPhones that don't work, right? All they want is a seamless way to manage their entire IT infrastructure. Cloud computing is great for that, right? Mobility, right? So being able to deliver care in a mobile setting. You go to a patient, you have their medical records, you can view their x-rays, you can view their images. A great way for technology that actually meets a need in the way you want them to deliver care. Consumer internet, increasingly becoming important. Benoit touched upon that in one of the slides, right? How do you get social, community of physicians and patients working with each other, collaborating with each other, actually creating an ecosystem versus having these islands that prevail. Digital media and entertainment. This is quite interesting, and I'll speak to one of our companies, Healthy Nation, that's creating healthcare videos for people to on various topics that could be of relevance to them. Intelligent systems, so the quantified self, right? The whole notion that you have all these sensors, you have all these phones, you have everything on you that is collecting vitals, collecting information about you, transmitting to electronic medical records, and creating a persona of you that's always available to physicians and to your caregivers. Very relevant for elderly care management. So speak to that when in a subsequent slide on telemedicine and our investment thesis in telemedicine. Clean tech manufacturing, those are areas Intel Capital Investments haven't found an intersection with healthcare, but except I guess if you have clean oxygen, you keep everybody healthy. So, but yeah, all eyes and ears if somebody can find how we intersect clean tech with healthcare. Skip that. What we have done by way of investments. Last year we invested over $500 million around the world in deals. We did over about 150 deals last year. We are increasingly very international, so a lot of our investments in healthcare and otherwise are happening outside the US. Last year we did a PACS deal in Brazil, a company called Pixion. They're the leader in the PACS market in Brazil. We are increasingly looking at healthcare services and other healthcare investments outside the US. These are all our investments that were done last year. Here is a company, CareCloud. This is one of my deals done in South Florida. I'll speak about them in a subsequent slide. Pixion is somewhere there as well. But obviously, healthcare for Intel, we are very opportunistic in what we invest in healthcare. We are very choosy about what we invest in healthcare. So there's a lot more that we have done in other sectors, but I'll speak to some other things we have in our portfolio as well. Skip exit. These are all the countries we are invested in. So at this point, Intel Capital is about 51 countries. And as I said, we are very actively looking at healthcare deals in pretty much all these different markets. Some of our past exits, WebMD was in our portfolio. That's a leading consumer healthcare company. Our syndicate program. So here is something called Intel Technology Days, and what we do is we work with leading organizations around the world, and we look at their innovation needs, and we work with a lot of very large hospitals. We'll work with Kaiser here, for example, right? And we'll ask them, what are your innovation needs? What is it that you are looking to do in the next 5 to 10 years? And we'll find companies in our portfolio in telemedicine, in mobile health, in consumer health, that we can then introduce to these companies. I'm increasingly finding that even Fortune 500 companies that are not in healthcare are very much interested in healthcare, because it's such a big part of your operating expenses that it's almost become as big a line item as let's say your R&D spend. Intel spends $500 million every year on healthcare. Our healthcare costs went up by 10% year over year. So now it's healthcare is getting the CEO's attention, because 500 million is a lot of money even for a Fortune 500 company. So now I'll come to some of the healthcare trends that we are investing in. The first one is on next gen provider and payer technology. So this chart on the right, it shows the adoption of EMR EHR in office-based physicians. And something to note here, people in the back probably can't see the numbers, went from 10.5% to 34%, right? So a 3x increase in the last 4 years. Very, very interesting. A huge disruptive trend. The first time, and 80% of physicians, by the way, are in small office-based practices, right? So first time in nation's history that healthcare is actually now being digitized, right? Healthcare records are now going to be available like your bank statements. I mean, it's such a revolutionary concept that things that we have been doing for 20 years in other industries are now starting to come in healthcare. The other interesting data point, this is from CMS, Center for Medicare and Medicaid Services. So people here might have heard of the meaningful use and the stimulus dollars for if you have an EMR EHR system. So you register with Medicare, and you start to get $44,000 per year for 3 years after you have registered. And just in 2011, number of physicians registered for incentives went from 25,000 to 136,000. So 6x increase in registrations, huge trend. And Benoit talked about pay for quality, trumping pay for volume. So we are very bullish on ACOs. This year was supposed to have been the year for ACOs. CMS bungled it big time. There was a lot more sticks than there were incentives for people. Sorry,
what's an ACO?
Accountable care organizations. So the idea behind accountable care organizations is you're paid by patient in a coordinated fashion across all the different entities that are providing care to the patient. So the hospital, the labs, the small physician practice, they all work together so that if you as a patient, you go and visit a physician who refers you to a specialist, and then you go to a hospital, and then you get some lab work done, and now then you go back in your home and a caregiver maybe visits you. The notion today is for everything is a transaction, right? And a doctor doesn't care if you have gotten the same test done elsewhere, right? For them it's a transaction. But the idea behind an ACO is that some entity or a pool of entities come together, they take the risk, and if they can lower the cost of care and they can actually bring it below the reimbursement that they are given, then they actually benefit from that, and they keep the difference between what the government pays them and what their cost to provide the service was. So big trend. We're definitely very bullish on that. I talked about cloud-based ambulatory EMRs. So CareCloud is one such company we invested in that's providing cloud-based medical records. Big data for clinical decision support. Again, a big trend. How many here watched Watson beat the candidate in Jeopardy, right? So check out the YouTube video of how IBM is pushing Watson in clinical decision making, right? So for Watson, they, I think, had probably a couple of terabytes or even more. I don't know how much data they fed into Watson, right? So all of Wikipedia, hundreds and thousands of past Oscar wins and Grammy wins, and pretty much the entire data that they could find, they fed in Watson for it to actually win in Jeopardy, right? Now imagine the same thing that for them trying to do this in clinical settings. They're feeding medical journals, they're feeding all the past records, patient records into Watson. And the idea being that at point of care, that you have this neural network built into Watson that can provide clinical decision making at point of care. And similar companies are starting to come up that are using competitive technologies. Very bullish on that as well. And lastly, payers, the Cignas, the Aetnas of the world, they will all have to become very consumer friendly down the road. If the healthcare reform were to come into play, I was listening to Rick Santorum's stump speech on the way here, and boy, he was vitriolic about Obamacare. So we'll see where that train goes. But if healthcare reform stays, the payers will have to become consumer friendly, and they will have to institute technologies that let consumers directly buy policies on healthcare insurance exchanges. So I think that's a big transition that we are watching, and we are looking at a few deals in that area as well. And Vocera is another one of our portfolio companies that's in a hospital communication space, selling into CIOs. The second big trend we are investing in is remote patient management. Intel has been very big in this space. We are on standards bodies. We are driving the Continua Health Alliance on remote patient monitoring and management. And the thesis would not be unfamiliar to anybody here. US is aging, Japan is aging, Western Europe is aging, right? All these societies, there'll be a lot more elderly people. The baby boomer generation will be aging, is already aging, and will continue to do so. So how do you keep people at home? How do you keep them in the lowest cost setting outside of the hospital? And the home is the least cost setting to do so. But you still don't want to compromise on care. You don't want your grandfather at home falling with nobody there to take care of him, right? So how do you make use of sensors? How do you make use of video technologies? How do you make sure that they're being taken care of while they're still at home? And so and it's not just for reactive care; it's proactive care as well. Can you have for things like chronic heart failure? Can you have them take their weight and their blood pressure and have that be periodically transmitted to a caregiver? And a caregiver comes online, looks at the data, they both chat, do a video chat, and that's it, right? And maybe there's no more action that needs to be done, but if something is off, then they can tell, the caregiver can tell the elderly patient, you know what, you should go see a physician right now because there is something here that I think you should be really worried about, right? So just those sorts of things can make a huge difference. So we have a portfolio company, Sotera Wireless, in San Diego, that's in this particular space. The third one is consumer mobile health. There are a couple other speakers who will be going into a lot more detail, so I'll not spend too much time here. But the idea is, everybody is going to have smartphones, 150 million, 200 million smartphones. They have a lot of sensors. We are all, I think, increasingly, even folks older than us are very comfortable with using these mobile technologies. So how can you take the consumerism, the devices, and how can you bring them together for us to be submitting information to personal health records, to electronic health records, etc. But we have two companies, caring.com, that's a community of elderly patients, and Healthy Nation, which is in the healthcare video space. And the last space that we are interested in is the whole genomic space, both retail and commercial, right? I think that's probably the biggest innovation to come in the whole biotech area in the last 30 years. And the cost of sequencing continues to come down. Intel's doing a lot of research on how do you take all that genome sequence data, how can you run computation against it. We are running some very large high-performance compute clusters in conjunction with universities, at University of Illinois, at Berkeley, at Stanford, and several such places. So these are all trends in the bioinformatics area that we're interested in. We were investors in Pacific Bio, which we exited, and we are also investors in Vitae Pharma, that's in the molecular screening space. Thank you very much. I look forward to further discussions in the Q&A.
Thank you. Fascinating presentation. I'm sure some people here will probably want to catch up with you afterwards. So now we're going to welcome Peter Kacandes on the stage. Peter has a background in systems and control and a minor concentration in semiconductor physics. He performed postgraduate research in robotics at the Fraunhofer Institute for Manufacturing, Engineering and Automation, and worked as an embedded systems engineer on digital and signal processing at the UPS R&D Center. He received a MS in electrical engineering and computer science and an MBA from MIT. Peter was at Sun Microsystems, where he worked in supply chain management and was the product manager for the Java APIs for XML and web services. Peter joined Adobe Systems as the product manager for the PDF and XML specification, and later he worked as a technical marketing manager in mobile and device business unit, where he worked with OEMs, operators, content providers, and developers on implementing the Flash platform in a variety of mobile and consumer electronic devices. In your free time, what do you do in your free time?
I'm a triathlete and I do West Coast Swing.
There you go. All right, come and say it.
Great. Well, this was, thank you so much for your introduction, Benoit. And this was a really fortuitous order that he chose, because I think what you just saw from Intel Capital is kind of the macro level view. And what I'm going to do is I'm going to sort of take it down a level into more of a practical implementational point of view. What does some of this mean from the actual user perspective? And the user, when I talk about the user, I mean that both as a consumer of these things and a user of these things, and also from a professional, because some of you may be health professionals and you also have your devices that you're bringing into your practices, or you participate in these workflows and in these processes. And so, the mobile device is really becoming a nexus, for a lot of these trends, and I think is going to be the central element that's going to be driving a lot of these innovations. So just a little bit more about my role. So I've been at Sony Ericsson for about 2.5 years now. Sony Ericsson was a 50-50 joint venture between Sony and Ericsson. And then late last year, after 10 years of the joint venture, they had an agreement to reevaluate the joint venture every 10 years. And as part of that, and if you look at the trends that have been going on in the mobile ecosystem, Sony decided to buy out the Ericsson 50% of the joint venture. So as of tomorrow, we are now officially, tomorrow we're having a big celebration. It's going to be Sony Day. And so we are going to officially be part of Sony, a wholly owned subsidiary of Sony Group. And we're going to be called Sony Mobile Communications. I apologize that we haven't gotten the new branding yet, and we haven't gotten the new templates and everything. So there's still, Sony Ericsson visuals on this presentation. So who we are, I'm not going to spend a lot of time on this. As Sony Ericsson, we called ourselves the Communication Entertainment brand. I think that's going to continue under Sony, but under the Sony Make.Believe brand. But the whole idea and part of the rationale for the Sony acquisition was to bring to fruition what they're calling the four-screen strategy, which is that to be able to provide your data, your content, your services across all four screens, whether that's the mobile device, the computer, the TV, or dedicated
gaming types of consoles. And tablets are considered part of mobile. Sony, I'm not going to go into any of this. So it's all history. Not really that important. But what is really cool, I have to say, part of the reason, it's been a difficult couple of years for Sony Ericsson. When I was a technical marketing manager for a flash platform at Adobe, Sony Ericsson was one of my clients, and Sony had phenomenal smartphones at the time. They were based on J2ME. They had the best J2ME implementation. The OSE platform that they had at the time was phenomenal, the most standards Java compliant, easiest to develop for everything. They were the best implementers of Flash. They actually had a bunch of phones that you could configure the UI and customize the UI using Flash. But Sony Ericsson, as an independent entity, did not have the wherewithal to completely come up with their whole new own platform to drive the next generation. And so over the last 2 years, we've been making that transition from the old Java phones to Android. I think about 90% of our volume now is all Android smartphones. This is sort of the new lineup. This is the Xperia Ion, which is going to be our US device for the first, coming out in Q2, and then for the rest of this year, which is going to be an AT&T specific device. And then the NXT series, which are our international versions of those devices, and that's the P, the X, and the U. And if afterwards, I have a bunch of these devices with me, if people want to check them out, I have some demos that I can show you where you can actually see some of the things I'm going to be talking about. We're also going to have a short video. And we were just at Mobile World Congress where we announced these other ones. If I look a little windblown today, it's because I was actually out, one of the things that I love about my job is I get to play with all these devices. And this is actually a device that's out now. It's our sports phone. It's an Android, fully Android junior grade, but it's also waterproof, dustproof, shockproof. You can take videos with it underwater. I have friends in my triathlon club. I've done swim stroke analysis of them. And I was outside today in the wind. I don't know if you knew there was a wind advisory today, testing the next generation of this phone. And I'm responsible for the health and fitness category. So we're going to be preloading some fitness games. And so I did 10 kilometers out there today. in my work clothes testing this this application on the new device. So that's why I'm a little discombobulated. Yeah, it's a rough life, you know. The flip side is that my colleagues, so we're, from a content perspective, we're organized into games and non-games. And so my colleagues sit around playing games on their mobile phones all day and testing them. So, you know, all right, they're playing games, I get to go outside and do stuff. You know, how we differentiate ourselves, we got a bunch of Sony cool technology that's inside, the Bravia engine, PlayStation certified devices, Media Go, all the Sony computer entertainment and Sony network enterprise stuff. And you know, part of the reason, even though it's been a very difficult 2 years in this transition from, you know, the Java phones to Android, I think we make really cool devices. You know, if you look at a lot of the Android devices out there, you look at them, they're really pretty plain. But one thing I have to hand to Sony Ericsson is they did a really good job on design. So, you know, on to the topic. You know, we heard a little bit about it in the first you know, talk, this idea of the quantized self. And you know, there's a class of people who are really interested and motivated to sort of you know more about themselves and are willing to do that. But the pervasiveness of the mobile technology is really making it to the level where anybody can sort of get access to this information to understand more about themselves, their health, their condition, their fitness, and connect, you know, with all of the social aspects of their lives. And you know, there's a couple of key technologies that I think are communicating to that. One that we've been very aggressive about incorporating into pretty much our entire line of devices that I'm going to tell you a little bit about tonight is called ANT+. And the other one is NFC, which stands for Near Field Communications. People always ask me what ANT+ stands for. It doesn't stand for anything. It's just a moniker that came up. It's a standard that's run by a company called Dynastream, and it's a consortium of companies that all come together to advance the standard. And the great thing about it is that it's open. If you have an idea for a medical sensor or anything, you can propose a new profile to the committee. You can implement it yourself, or you can suggest that they implement it, and they have a process for deciding and prioritizing which new profiles get implemented, and I'll explain a little bit more to you about that. You know, the other thing that's, you know, really, you know, driving this is this notion of wearable computing, which was also mentioned in the previous you know, presentation. And you know, wearable computing is a combination of these sensors, and then you know, the devices that the sensors talk to. And different people have different ideas about what the architecture of that communication should be. I think our view certainly is that the mobile device is sort of the center of that, and the sensors should communicate to the mobile device, because that really is the most personal device that people have with them pretty much all the time. You know, there's other people who are pushing that all the sensors should have their own you know, radios, and so they can communicate directly to some, you know, back-end service, but then they can only collect the data when you're close to them or close enough to them. You know, companies like Qualcomm, they have an incentive to drive that model because they want to sell as many radio chips as possible. I don't think that's a really practical model. I think people are going to be using their cell phones to do a lot of this type of stuff. And then just, you know, the connectivity. I mean, it's just becoming more and more ubiquitous. It's becoming more and more continuous. It's becoming more and more seamless. So, you know, you might be using the cellular network 1 minute, the Wi-Fi network another minute, Bluetooth, you know, the next minute, or some other, you know, type of thing. I'm sorry, did you have a question? No. And you know, that's really what is enabling these things, because you know, it's great to have that data for yourself and to be able to see it, but you might not have the expertise to be able to interpret it or to know what to do with it. But if you've got some sort of sensor that's monitoring your condition, you know, sure, it can give you an alert, but you know, you might not know what to do, but it can also connect through the cloud to your doctor or somebody and tell them, hey, you know, this guy is going out of bounds on this biomarker or this protein or this whatever it is, and tell him, hey, he's got to come in, or he's got to take action, or he needs to take his medicine, or something like that. And if you combine that with some of the advances that's being made in, you know, automatic pumps and things like that, you can get these direct feedback loops to automatically take action. Of course, you have to be really careful about that stuff, because you don't want something going wrong. And I have a background in control systems. I used to build robots, and if you got the control system wrong, the robot could blow up or run into things, and certainly in a healthcare case, you don't want pumping too much of something into you, right? So you got to understand the feedback loops and all that kind of stuff. So, but the other part of it is really the social element of it. I mean, I've just seen there's a lot of companies that are evolving now where they have these activity monitors, right? And they go into a company, and this is a service that's offered to try and help companies reduce their healthcare costs. And it's voluntary. People wear these activity monitors, and then they have competitions. And it becomes not like an individual thing, but it's like, you know what, we're going to beat the accounting guys this month. And it's amazing when you see the data, how just adding that kind of simple element of gamification, making it an internal sort of little competition between departments, immediately, once you start putting those types of incentives in place, and it might not be something that's not monetary at all, but just purely recognition or something, that you can drive some really good results if it's done well. It's interesting. I was just reading this month's technology review, which is, if you're interested in these types of topics, the MIT Technology Review is a fantastic thing. It's got a couple great articles on that this month, but I got to get going here. All right, so boy, this is a real eye chart, huh? So I'll just read a couple of these things. Key features of AMP+. It's compact, scalable, flexible, focused, proven. One of the things that was mentioned earlier was the Continua Health Alliance. You can actually do Continua protocol, because obviously when you're talking about healthcare data, you want an element of security. You can do Continua secure over AMP+. The cool thing is on the right-hand side here from your perspective is the interoperable product examples. I have here an example of a Timex heart rate monitor. I've got over there an AMP+ scale from A&D Medical. I hope I got that slide in here. I'm working with a company called Dexcom that does a continuous blood glucose monitor. That they have an application that runs on our devices, so that it's a transdermal patch. So it's continuously monitoring your blood glucose. And I've seen studies that have shown that by giving somebody the ability to continuously monitor their blood glucose, you can save $40,000 a year by avoiding low and high blood glucose conditions, because you avoid one emergency trip to the hospital, and you're talking thousands of dollars just in ambulances and all the other care that goes into that type of thing. So the opportunities are phenomenal, not just in cost savings, but just also in personal improvement of quality of life. So the other cool thing about AMP+ compared to some of the other technologies is that as a network protocol, it supports a bunch of different topologies, and that's especially important in healthcare scenarios when you're imagining all the different types of use cases that you might have and all the different types of care facilities. So you compare this to something like even Bluetooth Low Energy. Forget the whole pairing issue. Bluetooth is just not designed to support all these different types of use cases. So this is what I was talking about before. This is Dexcom with their continuous blood glucose monitor. This is an AMP+ transdermal sensor. So it's got like a tiny little probe. It's like microscopic probe that actually penetrates your skin, and then it communicates via the AMP+ protocol to an application. This is that device that I was showing you before. This is the Xperia Active. And this device, like I was saying before, can, so in this case it's acting as a reporting module for blood glucose. Over here, I have an example of a company called SportyPal, which did a bike mount for this device. You take a couple of zip ties, and instead of having your bike computer, you just mount that right onto your bike, and now all of a sudden you can get your heart rate, your speed, your cadence, your power, even your power per leg that you're putting out, so you can actually measure the differences. So it's very important for pro cyclists as they're trying to improve their measurements. The sensor is already FDA approved. They're expecting FDA approval on the application, which is a whole nother issue. So the FDA is about to come out with regulations about when does an application on a mobile device have to be regulated versus when does it not have to be regulated. And like I said, some studies have shown up to 40K savings per year. So with that introduction to AMP Plus, can we cue the video? I'm going to have one of my colleagues from our developer relations group give you a little introduction to AMP Plus.
Hi, I'm Marcus Hansen. Hi.
Okay.
I work for Sony Ericsson. Today we're very happy because we are the first mobile manufacturer that have integrated support for the AMP Plus.
See all the different
system.
sensors here.
This means that you can connect your Sony Ericsson phone to a large number of fitness and medical sensors. For example, you can use your new Sony Ericsson Xperia Arc to connect to a heart rate monitor when you're out running. Or you can connect to a pedometer that you can use when you're out running or walking. You can also connect all these sensors at the same time to your phone, or even more sensors. This is actually becoming a big thing in the sports industry. In the last year's Tour de France, 2/3 of the riders were connected to AMP Plus sensors. The Xperia X10 Mini, Mini Pro, and X8 will have this enabled in the forthcoming software upgrade in Q1 2011. And of course, the Xperia Arc will have this enabled when it hits the market. For more information about this, please visit Sony Ericsson Developer World.
All right, so I didn't realize it, but I've overrun my time limit. Sorry, I can talk about this stuff forever. Obviously I get very excited about it. I'm happy to talk to you individually about NFC, but I think we've got other guests that we want to hear from. So again, my apologies.
Thank you. Good luck with the next wind experiment. All right. So now we're going to welcome Paul Nerger. Oui, you like the French way, the American way, the German way.
Nerger.
So Paul is a 30-year computer industry veteran. He has been working in software development, product management, architecture consulting, sales, marketing, many functions.
Everything but human resources.
His previous positions have included general management and executive positions at a number of mobile startups, including App Central, Dotmobi, and Argo Group. Prior to working with mobile startups, he held executive positions at Informix Software, Silicon Graphics, Sequent Computer Systems, and Digital Equipment Corporation. Paul is an industry fellow of the University of California at Berkeley, where he lectures at both the Haas School of Business and the College of Engineering. He's a graduate of Washington State University and did executive postgraduate education at the University of Oxford's Templeton College. He's a former USAF officer and diplomat where he served as the Air Defense Advisor to NATO. He is a member of the Royal Air Force Club and a fellow of the Royal Society of Hearts in London.
Thank you. Yes. Hi. About 18 months ago, I was actually approached by one of our customers, the Greater New York Hospital Association. And they told me that hospitals were very special places. And I said, yeah, I've heard that before. Every industry I've ever worked in have told me that they're special. But over the 18 months, I've learned that hospitals are very special places. We trust them. It's where we go to see our doctors. It's where we go for our children to be born. It's where we will eventually go as part of the process of passing on. They are very special places. And one of the things that I love about working with the Greater New York Hospital Association is what they do. We're Happtique, and we're owned by Geneva. Geneva was established in the 1850s to help lower the cost of healthcare and improve the quality of care. I do point out to them the irony of that, given the statistics that you previously saw, because they have uniformly failed in that mission. And we need to do a much better job of doing it, particularly as we as a society age. GNIHA is actually as large as the American Hospital Association. As a trade association, they represent hospitals and the healthcare industry in Washington, D.C. and other lobbying organizations. But they also own a venture arm, and that venture arm is where the vast majority of the revenues of GNIHA are actually derived. In fact, GNIHA, although most of you have never heard of it before, is actually the largest trade organization in the world. Not only in healthcare, but in all industries. They generate over $10 billion a year in revenue. They provide most of the purchasing for most of the hospitals in the United States through their group purchasing organization. And we were invested in them specifically to look at the mHealth challenge and the mHealth problem. So what we do, if I can figure out how to do this, there we go. So what we do is, you know, we kind of looked at mHealth and we said, how can this help with this overall goal of lowering cost and improving quality? And we like everybody else, we saw all the statistics that were out there. But the thing that was, we fundamentally believed is that mobile health, because of its connectivity and because of the fact that we all have a mobile phone, and because we're more and more having tablets and this incredibly connected technology, had the basis of really doing something profound. But of all the statistics, the one that interested us the most was this one. 85% of patients say they want to get their mobile apps, not from iTunes, but from their doctor. If you remember the healthcare debates, if you remember when people, the rhetoric of that horrid time where people said, we love our healthcare system. We don't have a healthcare system in this country. We have healthcare chaos. I challenge anyone here, Germans excluded, because of the way the German system works. How many people here love their healthcare insurance company? Do I see any hands for the insurance company?
I like
We see one.
I don't love it.
Do you work for an insurance company?
Are you a millionaire?
Generally speaking, we don't like our insurance company, but we love our doctors. We love our hospitals. We love those people that provide the care to us, not the people that say, no, you can't have that. So one of the things that we really focused on was that. How do we empower that? How do we make an ecosystem that takes advantage of that? So what we did was our mission for the hospitals and for the caregivers and the professionals was to become the go-to place for them to learn about mHealth. The place where they could get the infrastructure where they could lower their cost and improve quality care by exploiting this technology. We played a very key role in passing the meaningful use legislation. We played a very key role in defining those medical, meaningful use hurdles. And, you know, so we wanted to take that even further from a technology point of view. And that's why I was asked to join this group. Even though I didn't know a lot about mHealth, I learned very, very quickly. So we looked at 4 problems that were out there. And we said that, first of all, we look at the apps that are out there, and you go into the medical category within iTunes, there's over 15,000 apps. 15,000 apps. I challenge anyone to find an app there. It's almost impossible. It's impossible for the professional, it's impossible for the patient. How do you know which one's good? How do you provide the ability for the hospital to manage the apps and the devices that they have on staff? As more and more physicians are using devices, how do you ensure that that app that they're using that needs to be HIPAA compliant is in fact HIPAA compliant? How do you ensure that that application that they're using is actually one that could be recalled if there was a problem with it? How do you know the quality of the apps? Of those 15,000 apps, the FDA has said, we're only going to deal with those apps that are dealing with clinical decision making, and we estimate that to be about 10% of the apps. Of that 10%, over half of them are going to be class 1 apps. non-invasive apps that all they require is simple registration. All you have to do is fill out a form, and you're now FDA certified. Yeah, the glucose monitoring is different because it's invasive, or there's others that are semi-invasive, and they have more stringent requirements. But the ones dealing with, I'm going to collect your information, I'm going to make a clinical decision, that's a very simple self-certification. And providers can't provide apps to their patients. 85% say that's how they want it delivered, but there's no way to do it. So we said, can we provide one solution? Could we provide a mechanism whereby we can empower the professional as well as the hospital to connect with the patient to be able to do that? So what we did was we came up with 3 products, all of them an app store. Imagine iTunes that only deals with healthcare, but also embraces the Android marketplace and all the other devices that we have. So it's non-application specific. We built 3 editions. The Enterprise Edition. It's branded for the hospital. UCSF. UCSF now has an app store. They can use that to distribute apps to their patients. They can use it to distribute to the staff. They can say, this is the EHR system that we're using. We don't use XYZ, we use Epic Canto. And furthermore, that Epic Canto, I need it branded UCSF because I have a doctor moving between hospitals and I don't want to confuse them. We provide that with our Enterprise Edition. Professional Edition, absolutely free. It's for the individual physician practice. By the way, the number of individual physician practices in this country are declining as more and more of them are going to hospitals because it's just an easier living. So as a result, however, we still provide the Professional Edition completely free. A doctor can go there and see the way we organize the App Store for them. And then the Patient Edition is how do you actually manage that element of driving that app out to the patient to get them to use it. The hospital substore, we brand it for them, and then we give them the control to take, these are the apps, these are the 100 apps that I want you to use as a clinician working in this hospital. Don't look at the 20,000. Focus on these. It gives that focus. To connect the hospital, the physician, and the patient together, we have a technology we call MRX. The ability to prescribe an app to a patient. It's a really relatively simple idea. You click on the button allows the physician to say, what's your email address? And then using social login technology and single sign-on technology, we provide an environment where the patient can then receive an email, click a button, and they download their own version of the App Store that allows them to see the apps that have been prescribed to them. A very simple way of driving that out. We eventually think that the payers will provide a role here, because eventually we believe they're going to be reimbursing these mobile health apps because they play a very vital role in this ecosystem, and we need to make them all work together. Curation. Whoa, this was the first big problem that we addressed. We looked at the number of apps that are out there. We have the iTunes marketplace, we have the Android marketplace, we have people that can't spell marketplace, but we had a ton of apps out there. Right now we estimate between medical, healthcare, and fitness, there's probably 35,000 apps. What we did was we took those apps, and the first thing we did was we hired the librarian from the Cornell Weill Medical School and said, look, can you help us organize these? And we started with this idea that we could create a two-dimensional matrix of the apps based on clinical topic and professional audiences. And as we started organizing these things, we found that some of these categories, these buckets got really big, like physician. So we had to break those apart. And then we now have a protocol that we have a team of professionals that look at these apps. The team that we have is now enlarged. We have physicians, we have nurses, we have pharmacists. We even have a veterinarian because there's veterinarian apps in here. So we look at these apps and we categorize them and we catalog them. We're being the Library of Congress for apps. And they're completely free. You can go to our website and download that. And as we get these categories that have too many apps in them, we break them apart. we just announced this. We announced this probably about a month ago. All of our customers came to us and said, what about quality of apps? We said, no, we're just going to be the Library of Congress. They said, no, you have to do the quality. So we actually bit the bullet. This is a gigantic problem, but we think we have an idea on how to do it. And the first thing that we did was we appointed a blue ribbon panel. So we have a physician. We have the head of nursing accreditation in the United States. We have, if any of you know him, ePatient Dave, probably the leading patient advocate in the United States. And we actually have Dr. Shuvo Roy from UCSF participating in this panel, so we have a technologist. And what we're trying to do with this panel is come up with the standards, both technical and clinical, for evaluating apps. And the reason why is there's a lot of dangerous apps out there. We're dealing with healthcare. There are apps out there that claim that using a photo, they can analyze the photo and tell whether a skin disorder is a malignant melanoma. That is dangerous. Fortunately, that one was banned by the Federal Trade Commission. The FDA didn't have their processes in place. They couldn't take action on it, but the FTC could. But there's other apps out there that claim to cure acne and claim to do everything else. Not to mention the number of medical marijuana apps that are in the medical app store. By the way, the #2 most downloaded medical app out of iTunes is a sex manual. It has nothing to do with medicine. So what we're trying to...
How can you say that?
You need to, good point. Very good point. But you need to take a look at this particular sex manual.
I mean, really,
Yeah.
everyone giggles and demeans anything positive about. I'm from San Francisco. Okay, anything positive about sexuality is somehow completely unrelated to health.
No, that's not what I was saying. This particular one had nothing to, it was pornography.
This is particularly distinct from traditional medical concerns
Yeah,
about
it's
sexual.
you know, I've been in mobile for a long time, and we used to talk about 3 Gs being games, gambling, and girls, right? And you know, the G was for pornography, and this one is a pornographic app.
So what's the number one downloaded? You said that
Number
was-
1 is actually it moves from time to time from Allscripts to Epocrates. Both very good apps. They're great apps, highly recommended. There's a lot of other great medical apps out there too. One of the things we actually do is we actually create the poll of polls. So we take a look at the apps recommended by UCSF, Harvard, Rochester Medical School, the National Institute of Health. We take a look at all those. We kind of join those together and kind of give that poll a poll. So we actually have that in the store.
And speaking of mental health, is there a special challenge, do you think, associated with the gray zone between things to keep you happy and things that might be aimed at people with mood disorders or addiction problems?
I know I'm not a clinician, so I'm not the right person to talk
But
about
just
that.
in terms of the structure of this review panel.
Absolutely.
challenges.
We do take a look at mental health applications. We look at a lot of those things. And it's really the panel that kind of takes a look at that. So this panel, unlike a lot of the other application certification processes, is going to be completely open. If you go to our website and you have any ideas, we want to hear about them, because it's going to be completely open, completely published. It's going to be changeable. It's not going to be the current app stores, the approval process are shrouded in secrecy. Why did Apple reject my app? They will tell you, but they will tell you only under NDA. You're not allowed to have the rules out there. It's a secret. This is not going to be a secret. Once we come up with the review board, what we intend to do is look at apps from 2 aspects. One, a technical aspect, where we look for malware, we look for if it requires HIPAA, is it HIPAA, those sorts of things. But at another level, what we're going to do is then take a look and say, okay, this is an app that should be vetted by the American College of whatever. And we want to get those organizations working with us to help do that. And from that, we come up with a process whereby we have reviewed apps. It's a big project. It's a massive project, but it's one that we've taken on and we're excited about. So what is our vision as Happtique? We really see, we provide cloud services to enable a combination of provider, physician, insurance plan, and patients to come together to actually implement mHealth, to make it work. We provide the app stores whereby physicians can prescribe apps. And then finally, we're trying to provide this Library of Congress whereby we can classify the apps, but also certify the apps. We're doing this as part of the for-profit venture of Happtique. And I've been involved in lots of startups. This is the first one I've done in mHealth. And one of the things I can say about, I love working with this group. I love working in healthcare. I feel that I'm finally doing God's work because we have to solve this problem. We get, fortunately, a lot of press. We just launched our product in the 1st of January. We have a number of hospitals that have already implemented, including Mount Sinai. We just implemented it, and it hasn't rolled out yet, but we've just installed it for UCSF, which I'm really excited about. We have a couple of other customers that we've just closed, including Children's Hospital of Los Angeles and Children's Hospital of Miami. So there's a lot of really positive things going out there. I'm really excited about the future because, you know, we have to solve this problem. You know, I get so passionate now about healthcare. I recently moved back from the UK after 25 years. And as an entrepreneur, having started multiple companies, if I had a choice, I would not start a company here in the Silicon Valley because it's too expensive. This concept that businesses pay for the health care of their employee has created a society that has become dysfunctional. It has created a society, if you notice the early charts, it showed that the health care cost in the United States, we are twice that of Norway, which is the 2nd largest per capita spend. Yet Norway covers their entire population. We don't. We're broken. Our healthcare system is broken. There's no doubt about it. So we need to get this fixed, and this is probably one of our greatest imperatives that we need to address. Thank you much. If you have any questions.
Thank you, Paul. That's fascinating. And I'm not in love with my insurance company, for the record. So the last...
I like insurance companies, by the way.
Yeah.
It's just I think that we need to get them in a place where they're not the bad guys.
Yeah.
Because it works in Germany, by the way.
Germans
Germans love their insurance company.
Absolutely.
Yeah.
Can I just ask a really quick question?
So
I mean, we'll ask
if you don't
you,
mind, we'll
sorry.
do the and I'm sure you all have a lot of questions, so we'll ask Nick to come to the stage, and after the last presentation, we'll do question and answer. So as a way of introduction, so Nate Hayes is the founder and president for Influencer 50, a pioneering influencer identification and engagement management company headquartered in San Francisco with offices in London, Munich, and Sydney. His career led him from being a marketing executive at EDS, now part of Hewlett-Packard, to a tech PR company where he managed the Microsoft account before founding his own agency. The agency quickly grew and represented such clients as HP, IBM, Adobe, Sun Microsystems, and Sybase across 9 different countries. He also then founded New Economy Partners, an international agency network comprising agencies in 17 countries. Hayes recognized during these years that targeting the real sales influencers was often the missing link to cost-effective business development. In 2003, he founded Influencer 50 and now works from San Francisco. Clients including Microsoft, IBM, Walmart, Oracle, Orange, Nokia, SAP, and Salesforce.com. He co-authored the groundbreaking book Influencer Marketing, Who Really Influences Your Customer in 2008. Nick. Thanks.
So I'm going to talk about how buyers in the new Health 2.0 market, how buyers buy, and if you're a vendor, then it clearly affects how you should be selling into your audience. Now, when we first started to work for healthcare companies, everybody used to say to me, there's two things that are important in this market. They're calls and there's social media. Now, before I start, does everybody, can you raise your hands if the word calls kind of means anything? Right, great, that's a 0. So what calls are key opinion leaders. And actually, virtually every industry has key opinion leaders. They just don't call it something like calls. So what I'm going to do in the next 15 minutes or so is examine some of the ways in which the Health 2.0 market is very different from any other sector in terms of how buyers buy and how sellers sell. But what I'm also going to do is try and draw some parallels with other marketplaces which the health market is actually very similar to. And it shows the direction in which some people in the health sector will be buying as we move forward. What I want to leave you with is an understanding of some of the processes that people in the health sector that affect them in terms of how we make our purchases. And it's relevant in B2C markets, in B2B markets. So, let's start. Thanks. Number one, very briefly, I want to talk about why talk about influencers. Why is it important in the marketplace that you're in? And the fact is that whatever marketplace, influencers make up such an important role in the buying process. Now, I could be talking to you about buying cars for yourselves, by buying houses, by buying enterprise decisions, in federal government, how they make policy decisions. This is all relevant. So 80% of anything that costs more than $20,000 involves 5 or more influencers. You go and buy a pair of shoes in a high street, and if you're one of the guys, we don't talk to anybody. We run in, run out, buy the shoes. Maybe some other people take a bit more advice from others. But the higher the cost of the purchase, the more people we involve in the decision. The larger the customer, the more influencers. The more regulated an industry, clearly this being a particularly regulated industry, increases the number of influencers again. And the fact is, if you're selling into the market, your sales force will never see and will never be invited to meet these influencers, because they're not the people who sign the check. It would be easy if you could, but you can't just Google them. Nobody walks around with a business card that says influencer. So, let's move on. There's a couple of generic slides, not particularly relevant to this marketplace, but relevant across the board. If you're an influencer in a decision, you don't just play one role. Something like a healthcare system might take, from the beginning of a decision to be made to the end, might take 5 years. If you're doing some kind of traffic planning, you might even be looking 10 or 15 years ahead. So some decisions take a long time to be made. And during that time, there are plenty of different, we've made 12 different sections, 12 different roles of influencer during a decision. Now, if you go to most markets and you say, let's say the car market, and you ask, who's the most influential in the car market? You might say, the media. Well, the media play a role at certain stages, but they don't necessarily plant the idea that you need a new car. Maybe they do. Maybe they don't scope what your car should be. To some people they will. Maybe they don't persuade you that the check you're about to sign is the right check, or maybe they do. But the fact is that different influencers don't necessarily take you through the whole process from beginning to end. And that, in this sector, may be a 5-year process. So different influencers will influence maybe the beginning of your decision, and then they'll have no role. Or they might have a role in the middle of the decision. Or you might not consider them until the checkbook's in your hand and you're just deciding whether to go for vendor A or vendor B. So influencers play a different decision. And wouldn't it be great if you knew what influencer was affecting your sales decision at any given time? How much would a salesman give to have a map of who they should be influencing throughout that 18-month, 3-year, 5-year period. Now, we're not there yet. That's one of the holy grails of what we're doing. But we're trying to understand who influences a decision at any one time. Because if you're a vendor, think of the marketing money you keep pumping into somebody who may have already had their say in the decision. So we're trying to effectively be like a rifle shot instead of a scatter shot. You can do TV advertising and you hit 5 million people, but nobody's got a clue where they are in their decision, and you're wasting 99.9% of that. So we're trying to find out who influences a decision at a particular time. Kind of make sense? Right. We can move on from this one pretty quickly. It's too much of an eye chart. What it is whoever, if you're a vendor, whoever your targets in the centre are, it doesn't really matter who we've written in this particular case. So you decide who these titles in your case should be. But these are the buyers. These are the people that sign the check. You as a vendor may be somewhere around the outside with a whole load of rivals. And the problem is, you want to get in front of these people in red, whoever you've decided they are. The issue is that the people in red don't want to meet you. Nobody wakes up one day and says, the first thing I'm going to do is go and look at a whole load of vendor websites and see if they're doing anything interesting. Which is what these guys would love you to do, but it's not going to happen. So what these people do, whoever they are, inoculate themselves by listening to these people in green. Now, we've actually identified 28 different categories of people in green, but for the sake of clarity, we made this into just a simple 10-way diagram. So what happens is the guys in red, who sign the check, only really listen to the guys in green. The guys in yellow, therefore, need to try and work with the green, but in fact all they do is they keep trying to get to these. And the fact is, when we map this onto how a company spends its marketing budget, we find that 70% of the marketing budget goes into 20% of the green groups. So some guys in green, who actually are listened to by these, get inundated with marketing messages and adverts and whatever else. But the vast majority get completely ignored, and yet they've got more sway with these guys in red than anybody else. So the way companies spend their marketing budget has no correlation with how buyers buy. Specifically to the Health 2.0 market, there's disruptive technologies. Clearly, social media's got a much more prevalent role than even 2 years ago. There's a high degree of player churn. Vendors that were in the market a couple of years ago have moved out, or have morphed or been acquired, and absolutely, as we've been learning today, there's a whole load of new entrants into the market. It's a highly regulated market. The pace of VC investment we were listening to start with has rocketed over the past few years. And social media, if it does one thing, it creates noise. Now, one of the messages I'd like to leave you with is that social media has little correlation with influence. It has 100% correlation with noise. So, what this new marketplace means is that there's a host of new would-be vendors who are new to the market, because the market necessarily wasn't the market 5 years ago. It's a shrinking time to market, and certainly I think we've learned from the world of the app stores that the time to market is minute compared to where it was pre-app store. The existing buyers are going to be badly targeted, largely because they will be targeted by people who aren't used to this market, so they haven't learned the protocols and how things are done. The new buyers won't know who to trust. We're back to the Wild West, and there'll be confusion. They're the guarantees of what will happen. Now, I was doing some research a while back, and there's a social media company that focuses purely on Health 2.0, it says. And the headline in their first line of their website was that 20% of the content generated by internet users mentions health in some way. So first of all, they're trying to promote the fact that the internet's really important for this market. And it got me thinking, 100 years ago, when people used to actually write letters to each other, in polite society, 100% of letters would include references to health, because everybody would say, I hope you are well. So the fact that 20% of words on the internet are about health is just rubbish. It's just confusion. So, what's being sold into the market? The Rock Group did a very open report quite recently, and they said, of the new marketplace, pretty much 50% of products are being sold into B2B, into healthcare providers, into businesses. 30% roughly as being sold into consumers, 20% into medical professionals. Okay, so that's kind of the new shape of the Health 2.0 market. Now when you look at, or when they looked at what these guys were selling, largest sector consumer websites, personal health monitoring, analytics, data sharing, and physician social networks. So that's part of the new landscape. And because it's new, there'll be the confusion. So, key opinion leaders, they're changing. You can't just say who was important 5 years ago is still equally important. Typically, they've been identified through primary research. So it's a research company calling up people saying, are you having a role in the progress of this particular trial or whatever? And if somebody doesn't answer, they get a 0. If somebody says no, they get a 0. That's a crazy view to start with. So it's self-selection. If you reply, you're suddenly more of an opinion leader than if you can't be bothered to reply. Protocol databases, which I'll come on to, and social network analysis, which has some advantages. The fact is, there's so much regulation and increasing need for transparency that a lot of the traditional key opinion leaders, their hands are tied. They may be opinion leaders, but you as a vendor are not allowed to get to them. You know, often for good reason. So what's happening? Increased transparency, increased compliance regulations, tighter control of conflict of interest, caps on physician payments. Most people think the number of registered, or not registered, but the number of understood key opinion leaders is reducing, and there's skepticism and even vilification of those that are. And if you think vilification's a bit far to go, look at this. So, in Australia, there's what's called, in the health sector, a register of influence, which is where people are invited, it's like Wikipedia, people are invited to find any link between a physician, a health organisation, a doctor, whatever, and any commercial activity. And so they list it. This goes on for miles and miles. It says, Bob, who's the physician in Sydney, once appeared in a advertisement for this product or was involved in a clinical trial. So, when he says it's great, you might want to reconsider. This goes on for reams. So, I know you can't see this at the back, but this guy, Brett Forge, who's a physician somewhere outside of Queensland in Australia, said, many thanks for the dubious honour of being included on your register of influence. It is an inadequate way of investigating medical corruption, but it may at least start a discussion on this vital topic. So this might be a key opinion leader who accepts he's basically being an opinion leader is now akin to being corrupt. You're not going to get opinion leaders asking to be an opinion leader if this is the reaction they get. So there are key opinion leader databases that many of the vendors buy. But the fact is, it's a moving target. So the databases that were brought up over the past few years are, by their nature, out of date. If everybody has got one of these databases, there's no advantage to anybody because you're all aiming at the same people. And basically, there's a lot of people who were involved on a clinical trial or an approval process at a point in time. But by the time you get to them, that stage, we looked at the wave earlier, they've had their say. So the key opinion leader databases, which are heavily expensive and heavily subscribed, are just out of date most of the time. And so what we did was we looked at what are the parallels between the way influence works in the health sector and some other markets. And just for a few minutes, I want to cover 3 companies we work for. IBM Healthcare, we do lots of Microsoft work and some of it's in federal government, and Virginia Tech University, who are doing some very leading edge health investigation work. So they came to us and they want to better understand how to get into the real top tier Ivy League of major funding. So currently they might win the 5 or 10 million investments. They want to win the 100 or the $500 million investments. So we looked at their work and the market that they work in to try and get the philanthropic organizations, to try and get the commercial guys, to try and get the federal government funding for these big healthcare projects. And in their sector, which is higher education, they have key opinion leaders. It's highly regulated. There's very formal bidding procedures. There's easy blacklisting. If you take somebody to lunch that's a decision maker or an opinion leader and they report it, that's you out of the deal. You would imagine higher education. Who thinks that online influence would be pretty important? These are highly educated, perfectly rich, very internet savvy individuals. We keep hearing about the role of social media. Look at this. So, those mentioned in the formal tender, the individuals that we found 150 top influencers into the higher ed market. Those who were actually mentioned in any formal tender was less than 10%. So if you picked up all of the formal tenders in the past year or two, you would get 10% of the names of the actual influencers. So we looked at who's actually prominent as tweeting or blogging. 12% of the top 150 real influencers, not the noisemakers, the people who really whisper in the ear of the decision maker. 12% either tweet or blog. No prominent outbound online presence, 88%. So that tells you that everybody who says you can just Google the names, or, well, I tweet a lot and I just see who responds, or, well, I go and sit on this forum and I see who's an active member. You're missing not just most of the people, the vast majority. So, the new influencers can be anybody from any of these. They're not in an official body. Anybody who says, oh, the most important people in our market are journalists or are industry analysts. There's no one block. Influential people are people, they're individuals. And so Bob from Capgemini will be really influential. And he sits next to Shirley from Capgemini, who's not at all influential. But they both have Capgemini business cards. And so there's no easy way of finding out who are the influencers. It's a tough process. If there was an easy way, we'd just press a button and order it. And so what I want to leave you with is that you've got to think what it's like for a prospect to actually buy your product or service and understand what it's like to be a buyer rather than to think what it's like to be a seller. And that's the reason why what we do, we can move from industry to industry, is that people buy from people. And although the industries are set up to sell in a very different way, and you need a lot of experience to understand how the sellers work, buyers buy in the same ways. You've got to understand who's consulted in the process, find a way to work with them, and think individuals. So the point that I want to leave you with is that the most important influencers are individuals. They're not companies. They're not organizations. They're individuals. The second thing is that social media has way more to do with noise than it does to do with influencers. And so the way I'd say it is that all of you can think in your home lives and family life of the noisiest people you know. They are not the ones, almost all the time, that you go to and ask their opinion on something. What we're trying to do, the easiest way I can explain what we do, as a final sentence, is that clearly you've all watched The Godfather. We're trying to find Marlon Brando. Because nothing happens in Sicily without Marlon Brando giving it the nod and accepting it. But if he was brought into current times, do you think he'd be tweeting all day long? Do you think he'd have a blog? Do you think he'd go and do every speaker op that somebody could give him? All of his foot soldiers who are out there, the 20-year-olds, who are out there with the shotguns on the street, they're the ones who are tweeting, blogging, and getting their name out all day long. But nothing happens without Marlon Brando giving it the nod. And so our job is to try and find who are the guys that are really important, who don't care about bigging up their own, reputation, but nothing happens without their approval. And the issue is that if you follow social media and you Google and whatever, and you think, I've got the names, I know who's important, you're getting the guys out on the street who are the wannabes. You're not getting the Marlon Brandos. So, on that thought, I'll finish. Thank you.
Great, thank you, Nick, and thank you, Brittany, for capturing. So I'm sure you all have a lot of questions. I'm just going to kick off actually the panel discussion. One question around adoption. So we saw a lot of very cool, very innovative technologies. How do you drive adoptions? Talking about patients, talking about payers, talking about employers, providers. What's the key for driving adoption for this new technology? Vibhor, you want to?
I think for me it boils down to incentives, right? I mean, we have seen in the healthcare market, EMRs, EHRs, as we were talking about it, and mobile health, sensors, a lot of different technologies, influencers, things we have heard about. It all boils down to incentives. The U.S. system, the incentive structure is all wrong, right? It's just, it's focused on driving more volume. It's focused on transactions. It's not focused on care, effective care, and removing duplicative care, right? So to me, technology would have to follow the incentives and not the other way around. Telemedicine, people have been talking about telemedicine for the last 10 years, and because there is no reimbursement for telemedicine, right? Telemedicine has not taken off, and I think all the other technologies that we're talking about, and EMRs took off because federal government finally said we'll put $30 billion towards this and we'll subsidize it, and because we think it's important for everybody to get for the entire healthcare system to get electronified. So the incentives to me are the biggest reason.
Okay. Any other thoughts?
I think you have to get the patients involved too. It's so meaningful use in these 24 hurdles that the government put in place in conjunction with working with the industry. They kind of said that if you're for every physician that implements meaningful systems that meet these meaningful use hurdles, you're going to receive a payment. And by the way, that payment turns into a stick at a certain point in time. So you're going to get, do it now while we pay you, because eventually you're going to get beat to death. That tends to focus the healthcare providers and the physicians to take action, although I would say a lot of the individual physicians that I talk to are not aware of that yet. But on the patient side, it's I think a more difficult thing. Certainly our physicians influence us. When you have a dialogue as a patient with your physician and they say, well, let's talk about your impending death, it tends to focus you. It tends to change your behavior, at least for a short period of time. And the question is, how do you sustain that? How do you really figure out how to get that to be a lifetime change, rather than just a particular change. And the challenge there is with each of the particular mHealth application or protocol or what have you, is how do you get that lifetime change? It's, I think that the initial dialogue gets the change. You know, I remember when my doctor said, you know, your cholesterol is crazy, you're overweight, you need to exercise more, you need to drink a glass of red wine a day. That part I went for. You know, the exercise thing, you know, and that, you know, can I take a pill type of thing. You know, we tend to do that. But then he says, look, you know, you're going to, you know, you have a 50% chance of a heart attack within the next 10 years. You know, knock on wood, that was 10 years ago. I'm healthier now and I eat better. But, you know, those are the sorts of long-term changes that we need to get. So it's, the incentive is also incentivizing the patient.
Okay. Back to the discussion around influencing. So what's the role of other patients to influence patients in terms of adopting this type of technology?
That's a good question, and peer groups are a phenomenal influencer. We measure, our methodology measures every influencer on 8 criteria, and you know, one of those is market reach. So you know, if you're a newsreader on a major show, you have a massive market reach. If you're a peer group and you occasionally get your word out to competitors as to what you're using or adopted or whatever, you may not have the reach, you may not very often get your word out, but the level of persuasiveness, which is one of the factors, is massively high. So we buy from some, you know, people buy from people. I buy from someone who represents what I think could be me if I was in that situation. And you know, you only have to look at how many more books are sold as a result of Amazon's peer group reviews. You know, we buy books that we're not actually that interested in, except that they've got 5 stars from a whole load of different sounding people who sound like they've been surprised how good it was. And we don't even know these people. They might be, you know, axe murderers. But we still buy. So peer group are massively important.
I mean, I think the thing that the term that we use on our side is what we call a community of interest.
Yeah.
And you know, we see the mobile device as, you know, making it increasingly easy for people to engage with, and especially in the healthcare scenario. People, if they have a particular condition or whatever, they want to engage with other people who are in that similar situation, to learn about their experiences, to support each other, to possibly learn something that they might be able to apply, you know, to themselves. And I think those types of communities of interest are going to be, you know, very influential in terms of, you know, how these things get adopted. The danger there, of course, is that obviously if it's not, you know, the rigorous double-blind thing, just because something worked for somebody and they tell their community of interest that worked for me, doesn't necessarily mean it's going to, because there's a whole host of other things that could apply.
So how do you educate patients in this case, where you have patients very active on communities for specific topics, and you want to make sure they deliver the right message, right? You know, both from an accuracy and you know, of course, talking about healthcare, so making sure it's.
Well, I think that's where
relevant.
things like Happtique, you know, can really come in, where, you know, there's a level of professional expertise that's applied to evaluating, you know, some of these things, that then, you know, somebody could say, oh, well, according to this panel that, you know, has some real bona fides, you know, they've looked at this sort of thing and they're saying that these are the top things,
Okay.
right? And then within that community of interest, things like that become very influential, I think.
But to be clear, you know, there is a very fine line. You know, one of the things that we've avoided doing relative to our certification program is we've avoided using the efficacy word.
Yeah.
Because efficacy has a certain implication about it with regards to a statistical clinical trial that you really want to avoid, because that's not what we're doing. We do get involved in, and I've been involved in some mHealth efficacy trials, either at IRB level or some of those have gone to inter-hospital levels. But, you know, that's a completely different realm, and that's dealing with.
I think the thing that's really important, though, is just, I mean, to your point, you mentioned this very clearly, there is so much noise out there, so that anything that provides a level of curation that somebody that you have some confidence in has looked at something and at least done a basic sanity check on it,
Correct.
then provides a huge level that somebody is willing to try something. In our case, for example, there's 500,000 apps in the iOS market, there's 400,000 in the Android market. We have a channel in the Android market that's actually labeled the Sony market. We can only promote 100 apps at a time. But we have the numbers that show that people are willing to try those apps, at multiples of, hundreds of percent more than any old random app on, just because they have some confidence in our brand and the fact that we're actually suggesting it, even though we make all kinds of disclaimers about, hey, we're not making any claims here, we're just saying that this is something that we think is interesting. So just that level of some level of sanity checking and curation gives people a level of confidence that they're willing to give a little bit more attention to something than that noise of hundreds of thousands of things out there.
So last question on my side, because I think most of you want to ask the panel questions, but do you see a correlation between the rating of the application, both on your side, Peter and Paul, and the source of who's producing the app, whether it's a physician group, whether it's a standalone company, whether it's a pharma company, a med device company? Have you gone through the exercise?
Yeah, absolutely. So I'll give the counterpoint to your example of the Amazon ratings, which is that there's a company based up here in San Francisco called Goodreads, right? So they've got about 6 million users, and but all of their ratings are based on your social network. So you invite people through a Facebook application to see, well, what are my friends reading, right? And so I am much more willing to give credence to what friends that I've actually taken the effort to connect to are reading and have recommended versus any random thing that I read on Amazon. And I think the same thing is going to apply to the healthcare case.
Okay. And I do, in full disclosure, I actually have a patent in the area of crowdsourcing. And I'm a big fan of crowdsourcing. I didn't originally start as a big fan of crowdsourcing. And the reason why was, at the time a colleague gave me a book called The Wisdom of Crowds, which I read, and I said, this is really interesting, but there's absolutely no quantitative or scientific basis to it. There's no mathematical proof of it, and because of my mathematical background, I was very skeptical of it. So I actually started looking at the mathematics of this and actually generated a proof as to why it works. And I can actually summarize it in very simple terms. For every idiot over here, there's an idiot over here that's going to cancel each other out. And as a result, it's going to seek the norm. That is the basis of the proof. It's why crowdsourcing works. By the way, it's why democracy works. The idiots cancel each other out. So we actually come to the true picture of what's happening.
So the truth is in the middle.
Correct. So the truth is always in the middle. It's just the nature of the way of these things, the way they work. But the element is, if you look at these kinds of problems, the things that, and this is where a lot of the research that I was doing was how do you look at poles of poles, right? Because those are, you have this pole which is kind of a wise crowd problem, and you have this other problem, but how do you actually manage those? How do you join those together in a systematic approach that allows you to measure the inaccuracies in those, but to build a bigger picture? So that's part of what we've tried to do with this kind of best of the best list that we have. So if you go to our app store, you'll actually see the best of the best. And what we did there was, we took a real simple approach. We didn't use the full algorithm that I developed. It's far too complicated. Simplicity is good. So all we did was we took a look at all of these apps that these various academic institutions, hospitals, well-respected institutions look at. And we just said, what's the common thing that's recommended? And we found certain things. Hippocrates. It's highly recommended by lots of different institutions. The MedPage Today from the National Institute of Health, highly recommended. By the way, it's free. PMR, highly recommended. There's certain apps that are out there for the clinician and for the medical profession that time and time and time again get recommended. And as a result, those are the ones that we feature. Those are the ones that we say, look, these are the ones that everybody's talking about. These are the ones that your peers are talking about. So it's pretty easy, I think, to find them.
All right, the floor is yours.
I have a question. Well, actually, I have two questions, and I think one might be sort of similar to.
It's only one per person.
Only one. Well, I really wanted to know a little bit more about how. I mean, I could think of many ways that you could do it, but how you're monetizing Happtique, and then secondly, because I'm sure I'm not the only one here who works with some type of app, and how involved are you with the apps that you're recommending? And how much information do you have, and how do you, if you have similar apps, how do you decide which ones to recommend? I know that's sort of a loaded two questions, but.
So
Did you hear in the back? Yeah.
we tried to avoid the recommending ourselves. So, you know, we publish our methodology as how we came up with this list. Relative to certification, we want it to be open to all app developers.
Right.
And there's going to be cost associated with it, and we will charge the developer to do that. We want to do that really on kind of a break-even type of basis.
You mean when that particular app is customized to your hospital, or?
No. When that app, if you want the app to be certified and
Oh, I
you
see,
want
right.
that stamp of approval, we haven't released what the stamp of approval is yet, but we kind of think that it's going to be associated with the college or the association that looks after that particular topic, clinical topic. So you might, I'm going to get in trouble if I start mentioning names. So if you had like the American Medical Association, they may in fact give a stamp on clinician, physician apps, or you might have the American Nursing Association give a stamp on a nursing app. Those are the sorts of things that we're looking at. But we want to provide equal access to it. And the idea was that the developers would come to us, submit the apps, they would give us access to the technology, we would evaluate it, both from a clinical point of view and what have you, and then we would give feedback to the developer and say, by the way, you passed, here's a check mark that you could use, or no, you didn't pass, here's the reasons why you didn't pass and what we would recommend fixing. Mm-hmm. So the process will be open and what have you. So that answers part of your question. The other part of the question is how do we monetize it? We actually, each of the hospitals, we license the software, the cloud services to the hospitals. Right. And they actually provide that. In terms of the prescribing of apps, we actually do get some transaction fee on that. In terms of if you
so you're
go...
sharing in the fees that the apps are charging directly?
Yeah, we do that through a combination of mechanisms. The Apple affiliate fees.
Mm-hmm.
Google doesn't have affiliate fees. Actually, Google doesn't even like us looking at their catalog. They're really strange. You know, we drive traffic to them, but they don't like it, which I find strange. But we also, we think that there's possibilities for advertising revenue. So we have a number of buckets that we think that we can monetize it and pay for it.
Where are you in this life cycle? Sorry.
We're right now selling to
Sorry.
hospitals. So
okay.
So
but I mean in terms of like how many apps and like if we had an app, let's say, that we wanted to have the stamp of approval, are you ready to do that or not yet?
No, in terms of certification, you have to give us 4 to 6 months because
okay.
the panel's putting together the process right now, and then we'll be ready to do the certification. In terms of your app, if you have an app already in iTunes, we've probably already curated.
Okay. Thank you.
So a frequent analogy, my question's really aimed at Paul. A frequent analogy to consumer self-management or the empowered health consumer is the rise of the financial self-managing consumer or the rise of mutual funds. And on the one hand, you have people who are very sophisticated and know what they're doing. And on the other hand, it turned out 10 years ago, a very high fraction of people visiting Vanguard, which is the smarty pants mutual fund family, you know, going after the more educated, were very confused about the inverse relationship between interest rates and bond prices, and therefore had no business whatsoever involved in managing their assets. I mean, it's sort of a disqualifying kind of failed test. What I'm wondering about, if you're going to have apps that are prescribed, is there any emerging trend to making sure that the apps are a good fit in terms of the cognitive and emotional disposition of the patient? I think customization of the game environment, of the ways in which information is formatted should be suited to a personality, particularly on something as life-changing and permanent as diabetes or severe cardiovascular or stroke, major sensory impairments. All those sorts of things are big life-meaning events, but shopping randomly or going where with your uncle says is a good idea is a terrible idea. And I'm wondering whether there's any thought about this, because it's kind of taboo. No one wants to talk about this patient is too dumb. But that's what doctors have to do all the time.
I think you're right, but I think that part of the issue there, and this is why we see the physician playing a very key role, and I should say it's not only the physician, it's the clinician. You know, it could be a dietitian, or it could be, you know, anyone in the caregiving community. And it's really, we have to trust the professional's interaction with the patient to do that. I think that what's going to happen in the future is that you're right, that these apps are going to be different. They're going to be more customizable. So for instance, one of the clinical trials that we're working on is with Mount Sinai. Mount Sinai's transplant unit does, and I find this number mind-boggling, they do 50 liver transplants per month. It's an astronomical
It's like an 18-hour surgery, right?
Right. It's massive. But the thing that's interesting about this is that what they're wanting to do is they're wanting to be able to create an app that we're working with them that will take the charting and move that in an outpatient environment such that they can hopefully detect earlier organ rejection. Because if you think about it, you just received a new liver and you're now rejecting that. That's a pretty, you know, from just the sheer cost of rehospitalization, losing the organ, a few things like that is pretty traumatic. So if you can take and use mHealth technology to extend that charting in such a way that you can detect that there's something going wrong with the patient, you know, that's probably something pretty positive. That's the theory behind it. But now the question is, what do you want to chart? That should really be up to your physician to say, look, these are the things we want you to chart. So when we look at a charting application like that, it really depends upon the particular situation, and it's really up to the professional working with the patient to figure out what that is. And we think, you know, certainly the discussions that we've had, you know, I'm a technologist, I'm not a clinician, but the discussions that I've had with clinicians about the technology is that's really what they want. They want the ability to customize this app for the patient at the time of prescription to say, look, this is what I want you to collect. This is how often I want you to collect it. You know, there's devices that can help you manage that and make it easier. And then, you know, here's the bundle.
I thought it was really interesting. I've spent 20 years working for or inside healthcare providers, and it's really interesting to see this and then look at it from their perspective. And the one thing I would say is that I don't think people understand, I do a lot of payment and regulation, that providers don't always understand how they're reimbursed for technology too. So when you actually go to them, you have to provide them with the information. For example, telemedicine is actually quite reimbursable, and a lot of providers that I know just are struggling with the leadership in order to be able to do that, and there's not a lot of people working together. And if they actually went to payers and said we want this reimbursement, had patients behind them, you would see more telemedicine reimbursement because there are not any regulatory or coding barriers to it. And the same thing to understand, I think, that's interesting is that when you're dealing with plans, for example, we live in two different reimbursement worlds. One that is the capitated world, which is very different from the fee-for-service world, which is going to continue to exist for the next 10 years or so. So when you're trying to market, understanding both of those worlds and how that impacts your technology is really important. And don't assume the provider knows it, they don't.
I think that they're getting smarter about it, the providers, and certainly, you know, that's, you know, our parent organization, that's one of the things they do in terms of educating providers about is, you know, what is the legislation and what does it mean to you. But I think you're right. I think that, you know, recently I went for a physical to my doctor, who's actually, he's a single physician practice. and becoming more and more a scarcity. And the reason why is it's getting harder and harder as a doc to run a business that way. And the reason why is that you have to deal with all of these things. I asked them, I said, what are you doing about mHealth? What are you doing about electronic health records? What are you doing about meaningful use? And it was like I was from another planet. I said, did you know that there are economic incentives for you to implement these things? No. Did you know that if you don't do it in such a period of time, that there's actually going to be penalties for you? Oh no. There's the lack of information out there. At least with the hospitals, there's an administrator that you can talk to and organizations like the American Hospital Association or the Greater New York Hospital Association. They can talk to them and educate them about that and provide an outreach for them. But we're going through a period of change and upheaval, which I think we need to do, because of all the problems we have with healthcare. But it's not going to be, it's a period of change.
And it just depends on your system. So I work with a very large physician group, about 7,000 physicians, and they're actually very sophisticated, and I can see they're different issues. They could actually use a lot of this technology to support the services that they provide to patients because they're reimbursed on a capitated basis. So it just depends who the market is, and it's a really complicated market, and understanding that when you go to the provider, what you can offer in each of their markets that they have for different plans or different physicians is really important.
Well, and one of the things I mentioned earlier is that I think that physicians more and more they want to be employees of hospitals because it's the safest way through this path of change in this turmoil.
My question was triggered by something Paul said, but if each of you could address it briefly, that would be great. I'm wondering about the international aspects of what each of you are doing, what influences or which ways you've incorporated the lessons from other areas. Norway was mentioned, the UK was mentioned, Germany was mentioned, and evidently you're from different places as well and will have had your experiences.
So in terms of healthcare system or in terms of technology?
It could be system, it could be technology, it could be the way people are influenced cross-culturally in their decisions about getting care.
Okay.
Whatever your world is, how are we thinking bigger than just America? America's big, sure, but how are we thinking bigger than just America in both of your respective spaces?
So I can start by a quick example. So for example, from an investing perspective, we see some of the things that have barriers here taking off much earlier in the emerging markets. So telemedicine, for example, we are seeing some deals in India where they don't have regulations like the fact that you're licensed in one state and therefore you cannot see a patient in another state. And there's a bill that will supposedly get introduced this year that will take away that restriction. The senator from New Mexico is introducing that shortly. So I think some of those barriers that have artificially been put in on how you practice medicine, right? Supply constraints. Other countries are doing much. They're not even constrained by those, right? The frugal innovation on some of the things like on med tech devices. There are people that are taking phones in emerging markets, converting them to all sorts of medical devices, but they don't have to contend with the FDA bureaucracy, right? And they can now lower the cost of some of these devices to $500 versus say $5,000, right? So frugal innovation and services and business process innovation, I think we'll see actually diffusion from the emerging and developing markets to the United States.
Intel Capital is investing in organizations in various companies.
Absolutely,
Okay,
absolutely.
thank you. Ed, I'm still.
I think this isn't unique to us, but I think also if you look at some of the different markets, there are just certain things that are possible in some places that aren't possible here. I was reading an article on the Fierce Health blog or whatever news site today, I think it was, or yesterday, where because like in England, for example, you have the National Health Service, where you have one unified system for how you handle health records. Well, there's a lot of companies who are doing very innovative things in terms of being able to look across all of those records to glean data to do all kinds of interesting stuff, which because of the fragmented environment and the lack of integration that we have here, you just can't do those same kinds of things with the same efficacy, right? Or the same efficiency, I should say. So yeah, it absolutely varies totally by market and what are the prevailing conditions in each region.
And can I just say that very briefly, that when we look at influence across, however many countries in the world, we always say that influence crosses borders, but it doesn't cross languages. So that when we look at most markets, America will be absolutely influenced by individuals in the UK, rarely actually Australia, but actually bizarrely more New Zealand. I don't really understand that one, but and Canada and India. Any major English-speaking country will influence each other in terms of how decisions are made and peer reviews and whatever. It doesn't cross any language. So you can be in a village in France, 3 miles across the border to somebody in Germany, and in any market, your top 100 influencers, who are massively influential to the person in France, will have absolutely no influence to a person 3 or 4 miles away who lives in Germany. So it doesn't go across languages, it absolutely goes across borders.
And, our focus is really on the U.S. That said, we've worked with the Ottawa Hospital Group, which is a single payer system, more like the UK system. We do have operations involved in the UK that, if you saw the Fierce Health publication on the paper that came out of the National Health Service in the UK, it actually talked about the prescription of applications, and that was actually work that we had done with them to start influencing that. But each system has their own problems and their own issues, and none of them are perfect. And if you go to the UK system, one of the things, it is a single payer system. You as a patient are never going to be presented with a bill. The health care that you get there, contrary to political rhetoric, is actually excellent. I was treated for malaria there. They did an excellent job of it. Knock on wood, I haven't had any more malaria flare-ups. But they really are, they're quite good. But the problem that they're having, if you look at the Cameron government, they're actually saying, well, wait a minute, maybe we're too centralized. Maybe we need to be a little bit more decentralized. Maybe we need to not, the UK government over the last 10, 15 years has struggled with coming up with a modern electronic health record system that spans this nation of 60 million people. And so they're saying, well, maybe we should take a more decentralized approach. Maybe we should allow the unit trusts to make more of the decisions themselves. Certainly I did some consulting to the Hearts and Essex Health Authority a while back. And, the issue that they were dealing with was the fact that, when NMR technology, which was developed in the UK, there's a shortage of machines. It's because they're all centralized. Could they come up with a more decentralized way? So each of these systems work a little bit differently. The German system is one of health insurance companies, but the health insurance companies are nonprofit, and they're actually rewarded based upon how satisfied the patients are with the health insurance company. That's why I excluded the Germans, because I knew the answer. You look at the Swiss system, it's more like the way the American system was, but they went through kind of the Obamacare thing that we're going through now. They went through that 10 years ago. You look at the Taiwanese system, yet again different. We spend 35% of healthcare dollars on administrative costs. They spend 3%. They're all just different, and you have to embrace them. But all of them are looking for ways of improving quality of care and driving costs down. That's the common thread.
All right. So I think we're out of time. But thanks again for your participation. Thanks again for your time. Thanks for coming over today, and we'll see you next.
Good stuff.
No, we're not.
Were they inviting us? Or?